Okay, picking up where we left off. So now let's talk about the irregularities that we can have when reading our EKG. So now that we know how to read one, there's some things that you can encounter. So we covered normal sinus. Now we can see sinus bradycardia. So what's sinus bradycardia? It's going to be the exact same as your regular sinus, except the R rate, right? When we're counting when we're counting for how many QRS complexes there are in that 6 second strip, it's going to be less than 60 after we finish our calculation, right? So for this guy, this example that I gave specifically, 1, 2, 3, 4, 4 times 10 is 40. 40 is less than 60. So now we have sinus bradycardia. So what are the signs and symptoms of bradycardia? Some of the causes are hypothyroidism, hypoglycemia, hypovolemia. You can have an MI. Some medications can also cause bradycardia, right? The signs and symptoms, you could feel dizzy. Severe bradycardia can give you loss of consciousness, shortness of breath, activity intolerance. You can feel cold. You can also have chest pain, right? So think of when you stand up too fast and you get really dizzy and you need to sit back down. Some of that could be because you have orthostatic hypotension, but also because you're at rest. Your base heart rate is going to drop, and then all of a sudden you stand up and you can't meet the demand of the energy requirements of standing up, right? Because your heart isn't beating that fast, right? That's an extreme example. However, that's what you should think of, right? So you get dizzy, right? You can pass out, have episodes of syncope, shortness of breath, right? So your heartbeat is very slow, okay? Our interventions, right? We always treat the cause. So atropine, okay? Atropine is one of the medications that's going to boost your heart rate. It's going to get you jumping again. Pacing, if you need a pacemaker, right? Always start, remember, we go least invasive, most invasive. So if you have a pacemaker, it's going to be external before it's internal, okay? Stop any drugs that are lowering your heart rate, obviously, right? Give oxygen if they need it. Begin IV access, right? So we're always going to treat the cause, okay? Now, on the opposite end of the spectrum, we have sinus tachycardia. So this is going to be the exact same as a regular sinus rhythm. You're just going to have a R count higher than 100 after doing your calculation. So rate greater than 100. Everything else remains the same as a regular sinus rhythm. Still regular. The P wave is still 0.06 to 0.12. The PRI is 0.12 to 2, and the QRS is 0.06 to 0.12, right? So what does tachycardia cause? It causes hypotension. It can what causes tachycardia? It can be caused by hypotension. So your blood pressure is really low, and as a result, your heart tries to compensate, so your heart rate gets jacked up, right? Hyperthyroidism, fever, stress, alcohol, caffeine, other drugs, medications, pain, even electrolyte imbalance. So specifically, if we think about potassium is one of those big electrolytes that can, potassium and calcium can affect your heart rate, right? So what are these signs and symptoms of tachycardia? You have dizziness, lightheadedness, syncope, shortness of breath, feeling of palpitations in your chest and your throat, chest pain, low O2, right? So almost the same, if you want to think about it, almost the same as bradycardia, but different manifestations. So this would give you that anxiety feeling when you've had too much caffeine and you haven't drank any water and you get that heart palpitation. Think tachycardia, okay? So again, tachycardia, bradycardia, sinus rhythm, all very simple things that we should all be familiar with by now. Now let's talk about premature atrial contraction. So let's break it down. Premature, so it happened early. Atrial contraction. So we're going to be focusing on our P wave here. Okay, premature atrial contraction. The rhythm is irregular. The rhythm is not regular because remember, it's happening prematurely. So we're going to have a normal heart rate, right? Normal rhythm, P, Q, R, S, T, and then the normal isoelectric segment, and then P, Q, R, S, T, and then boom, short segment straight into the P wave QRS complex, right? Usually sinus, but it depends on other factors. Remember, the rate is irregular. That's the key for this. The QRS is still going to be 0.06 to 0.12. The PR interval is still going to be 0.12 to 0.2. What can cause the premature atrial contraction is emotional stress, physical fatigue, right, from caffeine or tobacco, right? The signs and symptoms feels like your heart skipped a beat. Okay, so this is when like you're sitting there and you feel that really strange heartbeat. Hopefully you guys don't experience this, but it's a really distinct feeling of your heart skipping a beat. And what's happening is these heartbeats are getting closer together. You're jumping straight into the next heartbeat without getting the full ventricular relaxation, right? Now, what's our intervention? It really depends on the symptoms, but the removal of the trigger, right? So if caffeine gives you the premature atrial contraction, you're going to stop taking caffeine, right? If you're on an adrenergic blocker, you're going to stop your adrenergic blocker, and it gives you those abnormal P waves, right? So if it's ectopic, it starts from the atrium, right? So it comes from a location other than the SA node. So you remember the heart diagram that we've been drawing? I should just keep it up at this point. Okay, so we have our heart, we have the 4 chambers, we have the SA node. Okay, so realistically, this is the only place where I want my electrical signal to be discharged from. This is the only place where I want my electrical signal to start. However, in other circumstances, what's going to happen is it's going to start from somewhere other than the atrium. It's going to start other than the SA node, right? So let's say I have some rogue little nerve cells right here, and they're going to start their own electrical signal that's going to then play on the SA node, and it's going to start our chain reaction too early. Okay, I'm going to drink my caffeine, my rogue little cells are going to trigger my SA node, and my P wave is going to come early. Okay, when you drink caffeine, you pee. Your pee comes early. Okay, so I'm going to drink my caffeine, my rogue ectopic cells are going to be triggered, my SA node is going to have that premature contraction. Okay, so that's the ectopic, okay? And it comes sooner than it should. Remember, you drink caffeine, you pee, comes early. And it starts in the left or right atrium, and it travels across the atrium by an irregular pathway, okay? And it causes, again, your abnormal P wave. Yeah. Let's see. So some isolated PACs aren't that significant. So if this happens to you every once in a while where your heart skips a beat under certain circumstances, that's not too significant. However, if you have it frequently, it could indicate enhanced automaticity of your atria, and it could lead to other dysrhythmias like SVT. Okay, so we don't want this happening frequently. Once in a while, when you have a direct trigger for it, then you know the trigger, you stop the trigger, you're fine. If this happens constantly, then what they'll need to do, and we'll talk about it later, they might do some ablation where they go ahead and they fry off these nerves, right? So that signal doesn't happen anymore. Let's talk about aflutter, right? Atrial flutter. And this is one of the things where you're going to have to look out for stroke. So the rhythm can be regular or irregular, right? So the distance between our R's can be regular or irregular. The rate is going to be fast or indiscernible. okay? But the ventricular rate is slower, right? So the atrial rate is going to be super quick. So what you're going to see on your A flutter, right? There is no definitive like P wave. It's going to be flutter, QRS, 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 and it's going to continue with that flutter, right? So our atrial flutter, our atrial rate is super fast or indiscernible. However, my ventricular rate is going to remain the same, okay, or slower. Okay, our P interval is going to be indiscernible. I mean, realistically, you can't measure it, right? You can't measure the time because there are so many things that look like the P interval. It's indiscernible, okay? What can this cause? It can cause coronary artery disease, hypertension, mitral valve. Sorry, I keep getting this mixed up. What are the causes? Coronary artery disease, hypertension, mitral valve disorder, pulmonary embolism, chronic lung disease, or cor pulmonale, right? So these things can cause the atrial flutter, okay? These signs and symptoms, you're gonna feel heart palpitations, shortness of breath, anxiety, angina, dizziness, syncope, right? So think about it, your atria is contracting so many times from so many different places, you don't really have that good heartbeat, so it's going to feel crazy in your chest, right? Your heart's on a party. You are going to have those heart palpitations and that shortness of breath and that anxiety. What are our interventions? Primary goal is to slow ventricular response. Our calcium channel blockers are going to be used in beta adrenergic receptors, cardioversion, and antidysrhythmics. So we're going to use amiodarone, flecainide, and dronedarone. Okay, so we're going to use our calcium channel blockers. So those are the same things we use for Prinzmetal's angina, and we're going to use them again for our AFib, right? Calcium channel blockers are important. We're talking about muscular contraction. Calcium plays an important role in muscular contraction. We take out the calcium channel blocker. Hopefully we smooth out that heart contraction, and we take away your A flutter, okay? Remember your antidysrhythmics, amiodarone. We talked about cardioversion. They're going to try to shock your heart back into that normal rhythm. They're going to bring it back. And this is a different type of shock than when you're doing CPR. That's VTAC and VFib. We'll probably cover those in later weeks, right? So cardioversion. Again, so you're going to have your absent P wave, you have your sawtooth flutter, and this can lead to heart failure. Atrial attack dysrhythmia is identified by recurring singular sawtooth. So remember, it's that sawtooth shape, okay? It's going to lead to impaired cardiac output. Coumadin is given to stroke patients. So what's going to happen? So you have your atrias, right? Your atria is going to be in charge of taking in the initial cardiac input from the heart, right? So what's going to happen when I have an ineffective atrial contraction? That blood is going to sit in your atria for longer, okay? It might be a few seconds, it might be shorter than that, it might be longer, but what blood is going to do is it's going to sit inside your atria for longer since it's not being pushed into the ventricle. And blood does what blood does, and blood likes to clot, right? So what's going to happen? Your blood is going to sit in the atria, okay? Your atria is having the flutter, it doesn't know what it's doing, its head isn't in the right place, right? It's going to flutter, and then finally send it to the ventricles. The ventricles are going to send it out. But by that time, the blood has already sat in the atria for a while. That's going to cause blood clots, okay? These blood clots can travel throughout the body. They can cause pulmonary embolism, DVT, or stroke, okay? So that's why they're going to give Coumadin, okay? Coumadin is going to prevent your blood clotting. It's going to prevent your stroke, okay? Now let's talk about AFib. AFib is also a really important one to look out for strokes, primarily for the same reason that I just described. So for AFib, your rhythm is regular. The atrial rate is fast or greater than 350 beats, right? So those sawtooth, right? So the sawtooth in between, here's our PQRS, right? The sawtooth, these right here are going to look like teeny tiny little squiggles, and there's going to be greater than 350 of them per minute, okay? But the ventricle rate can vary, okay? It could be normal, it could be faster, it could be slower. The P wave is absent. I mean, can you really tell me which one of these is supposed to be the P wave? No, right? So AFib, the P wave is absent. The P interval is indiscernible. You can't measure it. The QRS is still 0.06 to 0.12. And it causes, the causes are like underlying conditions. So you have CAD, valve disorder, cardiomyopathy, hypertension, heart failure, pericarditis. You can have a stimulus. You can be on cocaine or caffeine, electrolyte imbalance. So you have a high potassium, right? So all of those can cause AFib. Okay. The signs and symptoms. All of these signs and symptoms start to look the same, right? After a while, palpitations, dizziness, syncope, lightheaded, fatigue, shortness of breath, angina, chest tightness. All of these are kind of universal, right? But what's our intervention? So our intervention revolves around the problem. So our goal is to decrease the atrial rate, right? This is bad. We want this to look more like this, okay? We want this to stop. We want actual atrial contractions. We want actual P waves, right? So our goal is to decrease the atrial rate, prevent stroke, and convert to normal sinus rhythm. We want it to go back to normal sinus. So we're going to give our good friend diltiazem, right? So our favorite calcium channel blocker, diltiazem. And that's going to hopefully help us get back to our normal sinus rhythm. We can give beta androgenic blockers like metoprolol, and we're going to give antidysrhythmics like dronedarone, right? So that we're going to use all three even. So we're going to give our CCB, our beta androgenic blocker, and our antidysrhythmics, okay? This condition causes the loss of effective atrial contractions. So again, your atria is messed up, it's not going to work. All right. So for what can cause this, so you have multiple of the rogue electrical signals that are causing your SA node to be triggered and then trigger your false atrial contractions, right? So you're having more than one signal coming to the atria, telling them contract, don't contract, contract, don't contract. And at this point, your atria is getting confused. It's just a poor little muscle. It's not going to contract appropriately, right? These AFib sessions could be paroxysmal, right? So they could start and end spontaneously, or they can be persistent and last greater than 7 days, right? These are most common and significant in terms of morbidity and mortality, right? So AFib can be fatal. 6% of people over the age of 65, and prevalence increases with age. Results in a decrease of cardiac output because of ineffective atrial contraction. So again, your heart can't pump blood if blood isn't entering the heart chamber, right? So make sure you know your atria, what it does, your ventricle, what it does, and this is all going to make sense. So your ventricles that are in charge of distributing blood to the rest of the body can't do their job if the atrium itself isn't doing its job, if the atrium isn't letting blood flow into the ventricle. Okay, so again, the blood stagnating in the atrium is going to increase the risk for thrombi, right? AFib accounts for 17% of strokes. And that's going to be it in terms of our EKG and reading EKG and our heart rhythms. So just a quick recap, we covered sinus brady, sinus tach, normal sinus rhythm, premature atrial contraction, atrial flutter, and AFib, okay? Remember, a lot of these signs and symptoms look the same. The way we're going to discern these is the description, okay? So AFib, the atrial rate is greater than 350 beats per minute. The ventricular rate could be normal, fast, or slow. The P wave is completely indiscernible. You can't tell, okay? Atrial flutter, the atrial rate is greater than 250, okay? So remember, it's 250 for A flutter, 350 for AFib, okay? That's a discernible. The P wave is going to be sawtooth for flutter, okay? So think of a saw and flutter, right? The letter F for flutter has these saw teeth, right? So letter F has saw teeth, atrial flutter has the saw teeth, okay? And the interventions are, a lot of them between A flutter and AFib are going to be the same. So giving the calcium channel blocker and beta adrenergic blocker and antidysrhythmics. You can even do the procedure to cardiovert the heart back into normal sinus rhythm. Okay, premature atrial contraction. Again, you're gonna have a irregular heartbeat, right? The distance between the R's are going to be diminished, right? So that happens prematurely. You drink caffeine, your pee comes early, right? And then we have normal sinus, tachycardia, bradycardia. Those should be self-explanatory, right?